I'll actually let Ben introduce himself since he's already up on stage. Ben Greenberg, who is the co-director of the Transverse Myelitis Clinic at Johns Hopkins Hospital.
Good morning. You can call me Ben, you can call me Little Doug, you can call me or Big Doug, depending on which way you're referring to things. I'm an assistant professor of neurology at Johns Hopkins. I joined the faculty a couple years ago, joined the Transverse Myelitis Center and Project Restore, which is a group that combines the Multiple Sclerosis and Transverse Myelitis Center. It's an honor to be here speaking with you today. I have the task of getting everybody in the room on the same playing field as we go forward through the weekend for all of the clinical and scientific discussions we're going to have. So I like to know the audience I'm talking to. You're under no obligations to identify yourself, but if you're willing, who would like to recognize himself as either a patient or family member of a patient who's been stricken with one of these diseases, transverse myelitis, DEVIX, MS, ADEM. Now, even scarier, if you're willing to admit this, is anyone here a neurologist? We've got a few. Even worse, any psychiatrists in the audience? There he is. Okay, we've got one. All right, good. So we come from diverse backgrounds, and the idea for the next 30, 45 minutes is to make sure that all of the language we're going to use, the clinicians, scientists, advocates, patients, all of the people who you're going to hear over the next couple days, that we're all speaking the same language. So I'm supposed to discuss and give you a background in terms of rare neuroimmunologic disorders. So if I start off by saying we're going to enter medical school at the Nervous System 101, the reaction I typically get is similar to asking my daughter to eat her vegetables. One of, you've got to be kidding. And my goal for today is really to make this more eating something you enjoy, something that will be fun. And I'm not sure this is working. So we're going to try and turn you into this by the end of the day. And the idea is to give all of these concepts, which we consider to be very difficult at first, to make them easy to understand and give us a framework for discussion. So let's talk about, again, if this is going to work, the nervous system. So you guys have heard about the brain, the spinal cord, the peripheral nervous system, and I could start with these diagrams and point out the central nervous system, the peripheral nervous system, and in about 10 seconds, 50% of you would be asleep, and the other 50% would be confused. So let's start with something that everybody here understands. Everybody here, if you're over the age of 18, have had a stereo system at some point in your life. For the rest of you, this is an iPod with speakers. And the idea for us is to understand how a stereo system works. So, you have a stereo and you have a speaker. Pretty simple. It's connected by a wire. When you want to listen to music, you turn the stereo on, music comes out. Works every time, right? So you use something that generates a signal, signal goes through a wire, you make a product, you make music. Amazingly, this is just like the nervous system. You have a stereo, which for the purposes of movement, we'll talk about the brain. You have speakers, which are your muscles, and you have wires that connect them. These neurons that go from the brain through the spinal cord, and ultimately a second wire that goes out to the muscles. Same idea. You have to turn on the power, and when you do, you make music. Your muscles move. Okay? No difference between a stereo system and your nervous system. This is now 3 months of the first year of medical school done. You've completed it. So in medical school, we like to talk about normal versus abnormal. So let's talk about what can go wrong with a stereo system. What happens if I go home in a rage and break the speaker? You can turn the power on and off all you want. You'll get a signal that goes through the wire, but you're not going to hear any music because there's no output. Let's say I go home and I break the stereo system. You can try to make music, but you can't even generate the signal. You can't turn on the on switch. You can also go home and take scissors and cut the speaker wire. In that regard, your stereo is fine, your speaker is fine, but you can't get the signal from point A to point B. So you have dysfunction. You have evidence that the stereo system is not working. So if you've ever looked at speaker wire, it's a copper wire, I think. Any engineers in the audience? Good. It's a copper wire, and it's got insulation around it. Your nervous system, your wiring of the nervous system is exactly the same way. You have a wire We're going to use the term axon instead of wire. It makes us sound smart, and we can bill more if we say axon. And instead of insulation, we call it myelin. Again, it's the exact same idea, insulating a wire. We've just changed the language. So instead of wires and insulation, we talk about axons and myelin. So there are a lot of ways you can damage your wires. There are a lot of ways you can damage the wires that connect your stereo to your speakers. What your body tries to do is protect these. And how does it do that? It tries to put a barrier around some of the most important structures of the nervous system to make sure that there is not anything getting in from the outside and causing damage. Now, you can have problems arise from the inside, but this barrier that takes multiple forms is there to protect invaders from coming in and doing undue harm. One of those barriers that you're going to hear discussed over this weekend is the blood-brain barrier. So your stereo system and wires are in an environment where dust, where bugs are flying in and out all the time. What this is doing is creating a bubble around the wires and around the stereo system to try and prevent some of those things getting in. We put a seal around the blood vessels that feed the brain to try and make sure only certain things get through and things that we don't want stay in the lumen, in the inside of the blood vessel. So when we put a barrier around your stereo system or around your nervous system, it's similar to putting the stereos and the wires in a cabinet, in a stereo cabinet in your house, or in the study, and locking the door. And the reason you do that is to try and protect it from invaders in your household that may look like this. So what happens, this is my cat, this is Jordan, what happens when Jordan gets into the study or gets into the, or near the stereo cabinet? He likes to walk around, he likes to look at what's inside, and if he's being particularly bad, he finds a way to get in. What does he do? Why don't I want him in there? What is the cat going to do when he gets access to the stereo and to the speaker wires? Well, this is what I find. You find him with the wires in his mouth. So one of the ways you can damage your stereo system is a cat coming into your house chewing on the wires. Now, even if I can't see the cat at that moment, how do I know he's been there when I get home? I turn on the power. You hear music, but what else do you hear? You hear static, you hear noise, it's crackling a little bit. The signals are not getting from point A to point B as quickly or as efficiently as they should. This is demyelination. When the insulation around the wiring of your nervous system has been chewed on by a cat, the signal doesn't get from your brain to your feet as quickly or as efficiently. If that cat keeps chewing, then he cuts through the wire completely, and then you don't get a signal at all. This is the difference between demyelination and axonal transection. In one case, the insulation is damaged, and you have a less efficient movement of signals, and in the other, the wire itself has been cut and can't be repaired. In your body, these are the cats. These are cells within your system, parts of the immune system. Lymphocytes, neutrophils, the eosinophils, basophils. We give them fancy names, but you can think of them as Siamese, tabby, Persian cats. And these cats are running throughout the house all the time, and they're supposed to stay out of the study. They're supposed to do what cats are meant to do in the house, and that's chase away mice, kill insects, keep things out of the house that aren't supposed to be there. So let's talk about the immune system in terms of its functioning. What is it supposed to do in the normal state? So you're going to hear us use terms like antigens, and you can think of these as the mice, or you can think of these as cat toys, things that the cat would recognize. An antigen is anything that will stimulate the immune system. One of the major goals of the immune system is to distinguish between self and non-self, and this is going to be a recurring theme when you hear about the immunology of these diseases. You want your cat to tell the difference between a mouse and your toe, because you don't want it doing to your toe what it does to a mouse. And so your immune system is there to differentiate these things. It's there to clear infections, such that when you get pneumonia, sinusitis, a cold, your immune system is there to fend off these foreign invaders. Interestingly enough, and we won't have time today to talk much about it, your immune system is actually one of the best defenses against cancer that you have. Because even though that cancer was originally a part of you, it's taken on a new form. So the immune system plays a big role in fighting off different types of cancer. What happens when the system goes bad? What happens when you have dysfunction of the immune system? So the first possible dysfunction would be that you don't respond to a foreign invader. So if somebody is immunosuppressed, either because of a disease or because of a medication they take, they may not recognize the bacteria or the viruses entering their system with the efficiency and capability that they're supposed to. The next possible dysfunction of an immune system is an excessive response to a foreign invader. You want your immune system to clear up sinusitis. You do not want your immune system to cause damage to the bone around the sinuses. You don't want it to get too aggressive in the course of its normal activities. That would be considered dysfunction. And finally, the dysfunction that we're going to focus on the most is recognition of the self inappropriately. Can your immune system get confused? Can it sometimes start to attack something in the house that it's supposed to be protecting? So this is a little kind of my version of a simple movie of an antigen and a variety of cells within the immune system, and these work on a lock and key mechanism. You need the key fitting with the right lock, and when it does, when it finds the right one, it activates the immune system. So here it doesn't fit, then it finds a fit, and all of a sudden that cell preferentially starts to expand. If this is a foreign invader, if that's pneumococcus causing a pneumonia, you like this. You like for more immune cells to get into the lungs and clear the infection. If this happens to be an antigen from a spinal cord, however, this is not the response you want. You do not want your immune system getting turned on by that antigen, and if it does, you do not want this much of a clonal expansion of that immune response, because that's what can lead to damage. So let's talk about, just give you a guideline. So is everyone through the first 6 months of medical school now? You've had Neurology 101, Immunology 101. You're ready to hit the wards, I promise. That's all you need in terms of practicing medicine. It's a little scary. So the diseases, however, that we're going to talk about during this conference are listed here. You're going to hear people speak about transverse myelitis, recurrent transverse myelitis, something called DeVix, neuromyelitis optica. We're also going to talk about something called ADEM, acute disseminated encephalomyelitis, and finally there'll be discussions about multiple sclerosis. What I want to do is spend the last part of this talk differentiating these at a basic level, because you're going to hear very in-depth talks about each. So let's talk about transverse myelitis. It's kind of a bad term in a way when used to diagnose a disease, meaning transverse myelitis by definition just means inflammation of the spinal cord. People with multiple sclerosis, people with ADEM, people with neuromyelitis optica can all have transverse myelitis. They can all have inflammation in the spinal cord. When we use this as a diagnosis, what we're most often referring to is an idiopathic transverse myelitis, meaning inflammation of the spinal cord that happened in and of itself with none of those other diseases going on. Most of the time, it's a one-time event, but it can recur, and we'll talk about that. It can either be in isolation, idiopathic, or it can be secondary to some other condition. So we talked about in the context of multiple sclerosis, ADEM, neuromyelitis optica. There are patients with lupus. There are patients with other autoimmune diseases, Sjogren's, where their immune system as a whole is not working right. It is not distinguishing between self and non-self well, and an innocent bystander is the spinal cord. As part of other neurologic diseases, this is just a symptom. So when somebody with neuromyelitis optica presents with inflammation of the spinal cord, we don't diagnose them as transverse myelitis, even though that's what they're having. This is a flare, an attack of their DEVIX. And hopefully that language will make sense throughout the weekend. Neuromyelitis optica is a distinct entity, separate from idiopathic transverse myelitis. And we're going to hear a lot about both of these today. So this is an immune-mediated attack of both the spinal cord and the optic nerves. It can happen at the same time or separately. So somebody can come in April with inflammation of the optic nerve, and then 6 months later come in with inflammation of the spinal cord. And if they meet a series of criteria, we get concerned about neuromyelitis optica. There are people who can have multiple attacks of transverse myelitis, multiple attacks of inflammation of the spinal cord, who actually are having neuromyelitis optica. And one of the tricks we are trying to sort out, one of the tools we are trying to develop, is how do we differentiate people up front when they first present? How do I tell the difference between somebody with idiopathic transverse myelitis and a first attack of neuromyelitis optica, and is it important at all? So I want you to keep those questions in mind as you listen to the speakers that are going to follow that differentiate these diseases and differentiate the treatments. I'm going to argue later on today in the afternoon that differentiating these is important to do, and the better we get at it early on, the better outcomes we're going to see. Some of you may or may not be aware of an antibody that was identified in the last several years at the Mayo Clinic, the neuromyelitis optica IgG. So this is now a blood test that we can send off if we are concerned that somebody has DEVIX. The reported sensitivity was about 70%, meaning when they looked at 100 patients with neuromyelitis optica, about 70 of them would have this antibody in their system. Whether or not it is the cause of the disease or just a marker of the disease, we don't know, but as we'll hear about later today, it gives us a lot of insight into how this disease works. So let's talk about, and I should have mentioned, you're going to see images. You're going to see a lot of... I'm going to step off for a second. Can you guys hear me still? Yes. I figured as much. Good. So if you look, I'm going to give you, you've had Neurology 101, Immunology 101. I'll do it over here and then on the other side so you don't get cheated. You're going to see a lot of images today. So I just want to give you a quick orientation to some of the things you're going to see. What you see on the screens here is an image of the spinal cord. This is a person, we're taking a slice of them right down the middle. These gray boxes in front are part of the spine. These are the bones of the spine. And you see a gray line in the middle surrounded by white. That's the spinal cord. On this image, what you see is that white is in the middle of the spinal cord. And if you compare the thickness of the spinal cord here versus down here, up here it's thicker. This white is acute inflammation. This is the immune system infiltrating the spinal cord, causing damage and swelling. So for everyone over here, here are the bones. This is the spinal cord, and this is the swelling. This is a classic MRI. So for the medical students in the room, burn this MRI into your brain. This is a great example of what we see in neuromyelitis optica. A long, sometimes called sausage-shaped, kind of rounded lesion that covers more than 3 vertebral segments. You count the bones, it goes longer than 3. This is the type of lesion we see in DEVIX. Okay? So if you have somebody present with a presentation of transverse myelitis, and this is their MRI, it should send up a red flag that this patient may actually have a first presentation of neuromyelitis optica. Okay? Now when we look at ADEM, acute disseminated encephalomyelitis, and it's just as it sounds. It's acute, it's all of a sudden, it's disseminated, meaning it's everywhere, and encephalo is the brain, myelitis is the spinal cord. So these are lesions we'll see in the brain and the spinal cord, more common in children than adults, but we definitely see it in adults. This is classically a monophasic, multifocal disease. One time only, but it hits a lot of places all at once. You look at the spinal fluid, it's inflammatory, and if you look at this MRI, which is a series of cuts from a brain of somebody with acute disseminated encephalomyelitis, what do you see? Lots of different lesions spread out. It's on both sides of the brain. And this is the acute inflammation. Those cells entering the brain, I'm not showing you a spinal cord here, and causing multifocal damage. One question that will come up is differentiating this, a one-time only event, from the first attack of multiple sclerosis, which in its first attack can have multiple events, and we'll talk about how you do that. Multiple sclerosis versus these is not monophasic, it's recurring, and it tends to affect the brain, optic nerve, and spinal cord. All right? So how do we put this all together in a framework? Transverse myelitis, just the spinal cord. Neuromyelitis optica, the optic nerve and the spinal cord. Multiple sclerosis, all 3. Okay? So there are patterns of what is affected within the anatomy that help us differentiate these diseases. So let's graph this for you in terms of comparing these diseases based on the number of lesions that are present and concern for relapses over time. So if you had one event versus multiple. So here is idiopathic transverse myelitis. It tends to be, this is a generality, not a rule, it tends to be one time, one place. Okay? Small number of lesions and not recurring. That's the tendency for isolated idiopathic transverse myelitis. Compare that to ADEM. This tends to be one time, monophasic, it's not going to recur, it shouldn't recur, but a large number of lesions. It's not one little lesion in the spinal cord. It's multiple lesions in the brain and possibly the spinal cord combined. Where does recurrent transverse myelitis fit in? Or excuse me, multiple sclerosis fit in with this? This is a relapsing remitting disease for the most part, meaning multiple episodes over time, and that's true for most patients, and multiple number of lesions. Recurrent transverse myelitis is going to be somewhere in between. It tends to stick to the spinal cord. By definition, it's not going to have things in the brain, but you'll have episodes over time. And finally, neuromyelitis optica, which is the optic nerve and the spinal cord with multiple relapses over time. Does this framework make sense? Okay. One of the things this is going to be important for is what I want to lay the groundwork for is what you should be thinking about and asking, or at least what I would be asking, as the speakers get up throughout the day to kind of put a context for all the different talks you're going to hear. So my first question is, can anyone in the room tell me why autoimmunity develops? And if you can, you're hired. Come to Hopkins. We'll sign an agreement later on today. Why does the immune system get confused to begin with? What is the trigger that starts all of this? Many of us have autoimmune tendencies. If I take everybody in the room right now and I test your blood for antibodies or T cells that actually recognize yourself, I'm going to find a large proportion of you have these antibodies and T cells in your system. And you may be completely healthy. You may have never had one of these diseases. Why do you not get one of the diseases? Why doesn't your autoimmune tendency take over? And why do some people get the symptoms? Is it a matter of access? Is it a matter of some people's cats can break into the study and chew on the wires, and other people may have those naughty cats running around, but they just can't get in. They can't get in to do the damage. Or is there some sort of regulation within the immune system? Is there some sort of grandpa cat walking around in some of us saying, don't do that, don't do that. And in others of us, it can't get the job done. What is the mechanism for losing the control of your immune system? What can we learn in terms of recurrences and episodes of attack? Why do some people who clearly have an immune system that recognizes self have a monophasic event, whereas other people who have an immune system that recognizes itself have multifocal and multiphasic events? What's the difference between a person with ADEM? On the mic. I can.
It's all right. Either way. Just one second.
You guys hear me? Okay. You can hear me? Okay, sorry. So what's the difference between a one-time and multifocal event? What differentiates patients? What is it about their immune system, their anatomy, their neurology that differentiates somebody with a one-time versus a multiphasic? What do all of these diseases have in common? In the audience today, Art Malore from the Accelerated Cure Project is here, and this is one of the things they focus on, taking all of these immune-mediated diseases and breaking them down. Because if we can find commonalities via the mechanisms of destroying the nervous system, or what immune parts of the immune system damage the nervous system, if we learn from the commonalities, we might be able to develop new ways to intervene among common themes. Whether you have transverse myelitis or DEVIX, there may be common points of damage where we can make a difference. But almost as importantly, if not more importantly, I think we need to sort out what makes these diseases different, because then we'll really understand the fundamental biology. Why do some of these diseases only affect the spinal cord and the optic nerve, or just the spinal cord, or all three? If you're recognizing self-antigens, there has to be some reason that differentiates the location of the attack. What differentiates relapses and responses to therapy? Most importantly, what I really hope people will take away from after this weekend is, first and foremost, rare does not mean untreatable. So Dr. Roth in his opening was quite right. As an emergency room physician, for the family practitioners, the internists, this is an incredibly important fact to get through, because neurologists do not see these patients first. When somebody has numbness, weakness, either mild or profound, they're going to one of two places: their internist or family practitioner or the emergency department. So it's great for neurologists all across the country to know these diseases and know the treatments and know that there are things to be done. It would be even better for our frontline physicians to have this understanding. And hopefully we can help get the word out that even though a disease is rare, does not mean it is untreatable. Stopping inflammation, that number of red cells that proliferated on the screen in the spinal cord all at once, will limit damage. If I can stop the ensuing attack, even after it started, I can preserve axons and keep signals going from your stereo to your speakers and keep music being produced. And finally, the last question, can we regenerate? And this is going to be a hot topic throughout the weekend for people who have been on the other side of damage, where either we couldn't intervene fast enough or our interventions did not preserve enough function. Is there anything we can do to bring back function to a damaged system? So these are the questions we should go forth with. About 6 years ago, and Doug or Cody will correct me, there was a meeting here in New Mexico. Both have changed. Doug, well, we won't talk. Cody's a lot older and is just as poised and effective as an advocate as she ever was, and has done a spectacular job putting this symposium together. It really is a treat for us to be in an environment where we mix clinicians from different backgrounds, scientists from different backgrounds, and most importantly, patients and families from different backgrounds, because it's in the free exchange of ideas, whether it's between centers, between physicians, between patients, or between patients and physicians, that we really advance the level of knowledge of these diseases and what to do. I need to thank the Cody Unser First Step Foundation for putting this together, Project Restore, which is a Hopkins group, the Transverse Myelitis Association, which needs to be listed up here, the Governor's Commission on Disability, and the University of New Mexico for being hosts for everything.